The Brunnstrom Approach is a method used in physical therapy to help patients recover movement after a stroke. It views recovery as a series of stages, each with unique characteristics. Therapists use this approach to understand and treat hemiplegia, or paralysis on one side of the body. It provides a framework for assessing progress and choosing suitable treatment strategies. Based on detailed observations of natural motor recovery, it helps therapists predict patterns of motor recovery. This predictability allows for better planning of therapy sessions. It also provides a common language for healthcare professionals to discuss a patient's condition and progress. Understanding these stages is crucial for physiotherapy students and new therapists. It aids in setting realistic goals for patients and their families. The approach acknowledges the role of primitive reflexes and synergistic movements as integral parts of recovery. Synergies are groups of muscles that work together as a single unit. Initially involuntary, these patterns can become more voluntary and controlled with therapy. The approach uses these early patterns as stepping stones towards more refined movement. Studying the Brunnstrom approach is important for developing strong clinical reasoning and decision-making skills. While newer approaches have emerged, Brunnstrom's principles continue to offer valuable insights into motor relearning after brain injury. The Brunnstrom approach was developed by Stina Brunnstrom, a dedicated physical therapist from Sweden. She formulated this approach during the mid-20th century, grounded in meticulous observations of stroke patients. Brunnstrom aimed to create a structured method for evaluating and treating hemiplegia after a stroke. The approach guides patients through predictable stages of motor recovery. A key aspect is the utilization of reflexes and associated reactions to initiate movement. The goal is to assist patients in regaining functional independence. Several guiding principles underpin the Brunnstrom approach. Recovery from stroke can mirror stages of normal motor development. Reflexes and primitive movement patterns are considered normal components of early recovery. Proprioceptive and extraceptive stimuli help evoke desired movements. Encouraging any volitional movement, even if initially abnormal, is emphasized. Influenced by neurophysiologists like Sir Charles Sherrington and Dr. Thomas Twitchell, Brunnstrom integrated complex concepts into a practical approach. Her method offered a more optimistic perspective on stroke recovery. It emphasized active patient participation and recognized the hierarchical organization of the central nervous system. Brunnstrom's approach was groundbreaking, providing a structured and optimistic view of stroke recovery. The Brunnstrom approach outlines 7 stages of motor recovery, from complete flaccidity to near normal movement. Stage 1, known as flaccidity, is the initial stage observed immediately after a stroke. During this period, there is a complete absence of voluntary movement in the affected limbs. The muscles exhibit no tone, a condition known as hypotonia. The affected limb feels heavy, limp, and unresponsive. Basic reflexes are absent or significantly diminished. Stage 1 can last from a few hours to several days or longer. The therapeutic focus during Stage 1 is on prevention and preparation. The main goal is to prevent secondary complications through regular passive exercises. Proper positioning of the patient is essential to prevent injury. Gentle sensory stimulation may be employed to elicit minimal muscle response. Educating the patient and their family about this stage is also important. Understanding the implications of Stage 1 helps in managing expectations and planning care. The transition from Stage 1 to Stage 2 marks an important shift in recovery. Stage 2 is characterized by the beginning of spasticity, an abnormal increase in muscle tone. Alongside spasticity, basic limb synergies may start to appear. Stage 2 is defined as the stage where spasticity begins. Spasticity starts to develop in specific muscle groups, often mild at first but gradually increasing. Certain primitive reflexes may reappear, and associated reactions become more evident. The basic limb synergies begin to emerge, although they are usually weak. In the upper limb, a flexor synergy pattern is common, while in the lower limb, an extensor synergy pattern often develops. Voluntary movement is limited, and typically part of these emerging synergy patterns. The therapeutic focus during Stage 2 is on facilitating early signs of recovery. Techniques such as tapping over muscles, light stroking, or quick stretching can help elicit muscle contractions. Associated reactions can be used to trigger desired movements. The goal is to encourage any active voluntary effort from the patient. Passive range of motion exercises continue to manage developing spasticity and prevent contractures. Encouraging voluntary control over emerging synergies is key. Understanding and managing spasticity is crucial for effective therapy. The therapist's role is to guide the patient through these early stages of recovery. The focus is on promoting voluntary movement and preventing complications. Stage 3 represents a significant point in the Brunnstrom model of stroke recovery. Spasticity reaches its peak intensity, with strong resistance to passive movement. Voluntary control of movement is present but confined within synergy patterns. Stage 3 is known as the stage where spasticity peaks. The patient can actively initiate movement, but these movements are stereotypical and lack flexibility. Attempting to move outside the dominant synergy is usually impossible. The characteristics of stage 3 include predictable but limited movements. The patient gains some degree of gross motor control within fixed patterns. The therapeutic focus in stage 3 is on achieving consistent voluntary control of synergy patterns. Repetition of these movements helps strengthen muscles and improve initiation. Therapists guide patients to use synergies in simple functional activities. Managing spasticity with regular stretching and positioning is a priority. Techniques to promote relaxation of opposing muscles may be introduced. The goal is to make these patterns more purposeful and controllable. Moving beyond the peak of spasticity brings the patient to stage 4. Spasticity begins to decline, and the patient starts to move outside of basic limb synergy patterns. Stage 4 is characterized by decreasing spasticity and the ability to perform movements outside of synergy. Patients can initiate movements that combine elements of different synergies or break away from them. As recovery continues, the patient may progress to stage 5. In stage 5, spasticity continues to decline, and the patient can perform more complex and controlled voluntary movements. The influence of limb synergies diminishes. The therapeutic focus during stages 4 and 5 shifts to encouraging movements out of old synergy patterns. Therapy activities help break down these patterns and promote isolated joint movements. Functional tasks become more complex and varied. Strengthening exercises for specific weakened muscles are incorporated. Coordination and balance activities become important components of rehabilitation. The goal is to improve the quality, versatility, and efficiency of movement. Therapists work on refining movement quality and promoting functional independence. The patient's increasing abilities are reflected in more complex therapy activities. Encouraging participation in recreational activities can be a key part of therapy. The focus is on enhancing overall functional ability and quality of life. The patient's progress through these stages is a significant achievement in their recovery journey. Approaching a more normal level of motor function brings the patient to stage 6. Spasticity is largely absent, and the patient can perform isolated joint movements with good coordination. Stage 6 is defined by spasticity disappearing and the presence of coordinated movement. The patient can perform complex and skilled motor tasks with greater dexterity and control. The final stage in the Brunnstrom sequence is stage 7, representing normal motor function. Reaching stage 7 signifies the restoration of motor function that is essentially normal. There is no spasticity, and individual joint movements are fully restored. The therapeutic focus in stages 6 and 7 adapts to the patient's high level of function. In stage 6, treatment focuses on refining movement quality and improving coordination, speed, and precision. Complex functional tasks are encouraged. By stage 7, formal physical therapy may no longer be necessary for many individuals. If minor deficits persist, specific exercises can address them. The focus shifts to maintaining achieved function and preventing secondary complications. Encouraging a full return to previous life roles is paramount. Not all stroke survivors will reach stage 7, but it remains the ultimate goal of rehabilitation. The extent of recovery varies among individuals. The Brunnstrom approach provides a structured pathway for recovery. It emphasizes the importance of careful clinical observation and understanding natural recovery processes. The approach serves as a reminder that recovery is a dynamic process. The Brunnstrom approach utilizes specific treatment techniques to facilitate recovery through defined stages. Facilitation techniques promote desired movements and help regain voluntary control. In the early stages, facilitation is key. Techniques such as tapping over muscles, light brushing, or quick stretching increase sensory awareness and trigger muscle activation. The Brunnstrom approach is primarily used for stroke patients with hemiplegia. It is relevant for individuals with significant motor deficits, including flaccidity and spasticity. Sensory input and repetition are fundamental to the Brunnstrom philosophy. Sensory stimulation helps activate dormant neural pathways and promote neuroplastic changes. Repetition of movements is vital for motor learning and reinforcing desired movements. The approach emphasizes meaningful repetition within functional contexts. The therapist carefully grades sensory input and repetition to match the patient's recovery stage. The Brunnstrom Approach provides a structured framework for stroke rehabilitation. It helps therapists plan and implement effective treatment strategies. The approach's principles can be adapted for other neurological conditions with similar motor impairments. The Brunnstrom Approach offers several advantages in stroke rehabilitation. It provides a clear framework for assessment and treatment planning. The defined stages offer a predictable pathway for setting realistic goals. The approach acknowledges and utilizes phenomena such as limb synergies and primitive reflexes. It is a hands-on approach, which many patients find reassuring. However, the Brunnstrom Approach has faced criticisms. Some argue it might reinforce abnormal movement patterns and hinder the development of normal movements. The sequence of stages is not always strictly linear or universally applicable. Despite criticisms, Brunnstrom's principles remain relevant in contemporary practice. Many therapists find its staging system useful for assessment. Understanding limb synergies is crucial for managing spasticity and planning interventions. The Brunnstrom Approach is often combined with other neuro-rehabilitation techniques. This integrated approach leverages the strengths of different methods. It facilitates the creation of a holistic, patient-centered treatment plan. The approach's emphasis on clinical observation and natural recovery processes is still highly valid today.